Welcome back to Skinfluence. I'm your host, Dr. Dustin Portela, board-certified dermatologist.
And I'm Austin Lee, physician assistant who's been practicing derm for 10 years.
10 years?
Yeah.
Technically, that's longer than I've been practicing derm.
Really?
If you include my residency, then I'm over 10 years, but I've only been out of residency since 2017.
Residency, I feel like counts.
I hope it counts.
Yeah, that counts.
So I had a lot to learn there in the early days, but today we're going to be talking about one of the things that we talk about pretty much every day in dermatology, and that is psoriasis.
Psoriasis, yeah, we see it very often in clinic. It is it's a complex disease. It's not just straightforward like you like some people may think, but we live in a day and age where it's very prevalent, but there's good medications, and so I'm excited to kind of shed more light onto this condition.
Which can be done with phototherapy.
It can be.
We can shed some light on psoriasis. We'll get into that. But psoriasis is typically a red, scaly rash that appears most commonly on the elbows, the knees, the backside, the back, the scalp. And it usually has this silver scale on top.
Yeah.
And it gets very flaky in severe cases. So psoriasis is autoinflammatory. A lot of people think that it's autoimmune, but it's not autoimmune. I don't know if you want to dive into the difference between inflammatory versus autoimmune.
Yeah, so autoimmune implies more of a systemic. It implies that your immune system is responding to something, whereas I'm blanking, not
inflammatory.
Autoinflammatory is where your inflammatory cells are signaling to your skin to do something irregularly. Yeah. So in psoriasis, your cells are signaling, or your skin is being signaled to go through a cycle too quickly. Yeah. You're pumping out skin cells prematurely. That's where we get a lot of that red inflammation, that flaking. Some of the flaking is a little bit of the white blood cells that are dying on the skin and shedding off, but it is not so much autoimmune. It's more of just a localized inflammatory condition that can be widespread throughout the skin, joints, nails, and other areas.
I like to explain it as when you have an autoimmune condition, this is going to be things like rheumatoid arthritis, lupus, Sjogren's syndrome. Your immune system has recognized something in your body to be foreign, and your immune system is directly attacking something else in your body. Whereas autoinflammatory is another part of your immune system that's responsible for inflammation that could be used to fight off an infection, is just overproducing inflammatory chemicals. And parts of your body can be innocent bystanders to that, but they're not necessarily specifically being targeted by your immune system.
Yeah,
You're kicking out all this inflammation. You see it on the skin. You feel it in your joints. Maybe you're having bowel trouble if you have inflammatory bowel disease, but it's not necessarily being directly attacked the way it might be in vitiligo or Hashimoto's or something like that.
Sure. And another thing is very often in people with psoriasis, typical inflammatory markers are normal. And even though you may have a lot of skin manifestations, you're not going to see a lot of blood work abnormalities. Even with psoriatic diseases, there's not really a lot of markers that are going to be elevated in psoriasis. More are being found actually, but historically we don't do blood work when we suspect psoriasis.
Right. The incidence and prevalence of psoriasis, when we talk about the prevalence, how many people have it, in general, it's understood to be about 2 to 3% of the population has some degree of psoriasis. And we'll talk about the varying types because it can occur on a spectrum. But 2 to 3% of people is going to be somewhere between 7 to 9 million people have psoriasis in the U.S. And of that, about 30% of the people with psoriasis will have a correlating condition called psoriatic arthritis, where the same inflammation that is impacting the skin also starts to impact the joints, which can be the hands, the knees, the sacroiliac joints of the hips, sometimes anywhere on the spine. And so psoriatic arthritis can be debilitating. It can actually destroy joints, whereas the skin is inconvenient and maybe socially stigmatizing, but in most cases is not going to be limiting your function day to day, but your joints can actually get completely chewed up by psoriatic arthritis.
Yeah, there's radiographic data to back that up, where people who have untreated chronic psoriatic arthritis, when they do X-rays, they can see the destruction, the diminishing of those joints. So, which is another reason why we want to be aggressive when we're treating those types of patients.
Right.
So we talked a little bit about the types. We have psoriatic arthritis, which is the joints. We have just psoriasis,
like plaque
vulgaris,
psoriasis.
plaque psoriasis, and then there's nail psoriasis, where it can, on the feet, and sometimes it can look like you have a fungus in your nails, but often that'll show up as like pitting or ridges, or what we call oil spots, little yellowish spots that show up in the nails. And it's not an uncommon thing where we see patients coming in saying, I've had these nail problems for years, and my primary care has been treating it as a fungus with all sorts of topicals or oral medications, and we look at it and go, well, it's psoriasis. Yeah.
Guttate psoriasis is another variation. So your typical plaque psoriasis is large plaques over the knees, the elbows, the butt, the back. But guttate psoriasis, guttate means raindrop. And you get tiny little specks of psoriasis all over the body. And it's often confusing when it happens because it just looks like you have some other type of rash because the spots are very small. So guttate psoriasis, and then the most concerning type of psoriasis is erythrodermic psoriasis.
Yeah.
And these patients, they don't necessarily get the plaques, but they are red from head to toe. And when you have inflammation in 100% of your skin, your blood vessels are dilated, and it can be very hard to maintain your body temperature appropriately. You lose more water. So erythrodermic psoriasis is a potentially life-threatening condition.
Yes. A lot of electrolyte abnormalities because you're not retaining water very easily. Erythrodermic psoriasis often happens when psoriasis is misdiagnosed or mistreated, and the patient has been given steroids, intramuscular steroids or oral steroids, and it calms things down. They feel great, and then when they come off, it rebounds into that. I've seen that a couple of times, and it can be pretty scary for the patients. Usually, if we see that and they're not doing well, if they're febrile, things like that, we send them straight to the ER. But yeah, it's another type of psoriasis that we see is called inverse psoriasis.
Inverse psoriasis, yeah, good call.
Where instead of psoriasis on, like we talked about, the elbows and knees, which are the more common areas, we see it in the body fold. So like the ears, the scalp is for some reason considered a body fold, but we see it in the belly button, in the body surfaces, in the groin, in the inguinal area, and very often that can be misdiagnosed as like intertrigo or yeast or fungus or things like that, but it can just show up in those areas.
Yeah, and it doesn't look like your classic psoriasis. It doesn't get the silvery scale because it's wet in there.
Yep.
So it maintains just that pink, purplish color. So, yeah, inverse psoriasis is, you're usually a hero as a dermatology provider when you make that diagnosis and you get that cleared up for the patient because they've been misdiagnosed for a long time. So the understanding of psoriasis has evolved a ton over the last few years through the pharmaceutical industry, who's developed some very novel therapies. But what we understand is that this is largely a T cell abnormality that produces inflammatory cytokines. Cytokine is just like a chemical in your body. Some of these that can be elevated can be something called TNF alpha or tumor necrosis factor alpha, interleukin 17, which is another pro-inflammatory chemical, interleukin 23, which is another one. And there are other pathways we'll talk about that can treat this, but they all kind of work upstream of these common inflammatory chemicals, where if we had the assays routinely to measure these, a patient that presents with bad psoriasis may have elevated interleukin 17, interleukin 23. And there are academic centers when they're doing these clinical trials where they can actually look for how much interleukin 23 or interleukin 2017 are present in the skin of skin biopsies of patients with psoriasis.
It's interesting, and then tailor it to the... That's interesting. Yeah. So what are some common triggers that you see for psoriasis? Is it just show up out of nowhere, or are patients doing something to cause this, or is there something else going on that makes it flare?
In most cases, you didn't do anything or fail to do something that caused your psoriasis. There's often an underlying genetic predisposition. So we know that with certain autoimmune conditions, they run in families. With certain inflammatory conditions like psoriasis, they may run in families. Where it's like, oh yeah, my dad had psoriasis. That makes sense what this is. So there's an inheritability component to it. But if you have a predisposition and you go through a period of intense stress that weakens your immune system or tilts the balance of your immune system, stress could be a trigger. It's often underappreciated that medicines can be a trigger for psoriasis. Beta blockers, which are commonly used for blood pressure management or heart arrhythmias. Lithium, which is used in a lot of mood disorders. Very common alcohol. I've had patients who are very heavy drinkers that have bad psoriasis. And in those times when we can get them to cut back on the alcohol, their psoriasis often improves. So there are triggers that you may be partly responsible for, or maybe your doctor gave you a medicine that triggered it. And oftentimes if we can get you off of that medicine and get you an alternative, the psoriasis can get better. And then certain infections can trigger psoriasis as well. So
ironically, there's a medication called a TNF inhibitor, tumor necrosis factor inhibitor, which you'd mentioned is a tumor necrosis factor, plays a role in this. And it treats psoriasis, but can ironically cause flares or psoriasis to appear. And that is always unfortunate when we see that happen.
And patients may be given that to treat Crohn's disease, and then all of a sudden they've got psoriasis, and it's drug-induced and very challenging when it's controlling their bowel disease really well. But now they have skin problems. So that is kind of an interesting conundrum when that happens.
I know.
But it's not just a skin disorder though either. There's a lot of comorbidities that come along with psoriasis.
Yes. So I've been finding more that obesity is linked to psoriasis. Diabetes can be associated with psoriasis. So, and then like we talked about, bowel issues can be linked to psoriasis. All these different other inflammatory conditions can be linked to psoriasis, or can be shown to run in association with psoriasis. So it's not just a standalone thing, but it can show up with other types of conditions. And like you talked about, being on medications to treat some of these things can run with psoriasis as well. So
if you do have psoriasis or psoriatic arthritis, treating it may not just help the skin, but may help to reduce your risk of diabetes, of obesity, of cardiovascular disease, stroke, because when you have this elevation running wild in your body of inflammatory chemicals, it takes a toll on many organs in the body. It's not just the skin or the joints. That's just where we can see it and feel it. But if it's causing inflammation of your heart, your blood vessels, your metabolic system, that's something that when we manage it and reduce your risk, can add years to your life. So,
and another thing that we see that runs with it, but that can worsen it, is depression and anxiety. And studies have shown that people who struggle with psoriasis struggle with depression more so than the general population. Because of the stigma that goes along with psoriasis, where they go out in public and people see them with a rash, and it can be on their face. It can be severe, dripping from their scalp onto their forehead, and people, they notice and maybe look at them funny. They feel like people are just watching them. And then that stress of going out in public or being around other people makes it worse. And it's just this vicious cycle that they truly do struggle with. And we're here as dermatologists to help them, but also we're doing podcasts and we're on social media to help the general public understand who don't have this, that psoriasis is not a contagious thing. It's not a bad thing. It has nothing to do with the person who is struggling with it, that they're doing anything wrong. It's something that they have to live with, and it's a constant struggle. There's no cure for it. So even medications that are controlling it, they may get flares.
I've had patients come in who are wearing long sleeves, long pants, hats, because they don't want their psoriasis to be seen. And we get them treated appropriately. And the next time they're coming in shorts and a t-shirt, and their hair's done, and they're smiling, they're looking you in the eye. And it's so rewarding because you haven't just helped their skin, you've changed their life. So it can be very debilitating from a mental health standpoint as well, as can many skin diseases. So
when I was training, my attending physician, he often said that his psoriasis patients are often more grateful to him for helping them than the people that he's caught skin cancer on.
Mm-hmm.
And I have found that to be the case sometimes, where these people, their lives are changed when their psoriasis gets cleared. So it's a daily thing they have to live with, and it's hard.
So that's some good background on psoriasis. What are the causes and some of the other associated conditions with it? Let's jump into a little bit of Did You Know?
So on the topic of psoriasis, interestingly, psoriasis, the only indication that a person has psoriasis can sometimes start with just nail abnormalities. Their skin will be perfectly clear, but they've been struggling with nail issues for years, not understanding why. And it's because psoriasis that can be the presenting sign.
Yeah. I've got a couple to touch on. One is if you have moderate to severe psoriasis, then you have a 50% increased risk of cardiovascular disease.
Yeah.
So if you have uncontrolled bad psoriasis, your risk of having a heart attack is higher than somebody without psoriasis.
Because of the inflammation in the vessels.
Yeah. The other thing that I really find interesting, and psoriasis does this, there's some other conditions that do too, is something called the Kebner phenomenon.
Oh, yeah.
So Kebner was a dermatologist that described this kind of phenomenon. And essentially, psoriasis can appear in sites of trauma. Mm-hmm. So if you get a scratch, a scrape, or a poke on the skin, you may find then that psoriasis starts developing around that area.
Yeah.
And I remember as a resident being called to go do a consultation in the hospital for a new rash. And I went in, and the patient had started to develop a psoriasis plaque around their IV insertion site.
No kidding.
And the internal medicine team was concerned that they were getting a skin infection from the IV. But I was like, no, this is just psoriasis, and we can treat it with some topical steroids and keep the site clean. But if you move the IV site to the other arm, they're probably going to get it there too.
Yeah.
And so it's reassuring and helpful to the patient to know that it's just psoriasis. And we can manage it. We don't have to stop your IV, antibiotics, whatever it is. So if you get a cut or a scrape and you start getting psoriasis, it's because that's what psoriasis can do. Vitiligo is another one that can do that too. Lichen planus can do that. So the Kebner phenomenon is always interesting.
I remember when I was first when I was working in dermatology and learning more about psoriasis, there's another sign called Nikolsky sign, where if you pick at it, it bleeds. Like you get pinpoint bleeding.
Yeah.
And I was learning that alongside of learning about Kebner phenomenon. I'm like, that's just mean, because you pick at their skin to see if they have psoriasis. You see the pinpoints and he's like, oh yeah, you have psoriasis. And now you're just inducing it elsewhere because you're just picking all over their skin. You're like, oh, you're bleeding here. I was like, who's doing this?
So, well, let's jump into part 2 of the podcast.
Yeah.
So management of psoriasis.
There's a lot of ways to manage psoriasis these days, fortunately. I never practiced in the days when it was just tar.
Yeah.
He would prescribe tar.
Coal tar.
I can't even picture like how they would get that at the pharmacy or anything, but I would imagine it's the sticky, nasty mess.
Yeah. Yeah. It's not like the stuff you'd find in the La Brea tar pits necessarily, but it's similar.
Yeah.
It's stinky.
Yeah.
But the tar was shown to reduce that hyperproliferation of the keratinocytes, meaning they grow so fast that they don't slough off. You get that scale, and tar helps to decrease the proliferation of the keratinocytes. And so coal tar could be an effective treatment, and we still use it, but generally in shampoo.
I use it, actually. I use tar-based shampoo sometimes when my scalp gets a little itchy.
It can be very helpful for scaly and itchy scalp.
Yeah.
And then there was another type of treatment called Geckerman therapy. So Geckerman therapy is that the patient would have the coal tar put on their skin, and then they would be put in the light box.
Oh, interesting.
So they would use UVA or UVB, and they'd have the light shine on the skin with the tar, and it was even more effective. And this was done before the days of topical steroids, before any of the systemic treatments that we had. It was really, you had to put this stuff on your skin. And people would be admitted to the hospital for a week just to get Geckerman therapy, who was a dermatologist at the Mayo Clinic in Minnesota.
Interesting.
Who kind of pioneered that treatment. So coal tar, yeah, you went back to the early days.
Yeah, I was like, let's start at the beginning.
Yeah.
You know, I always thought the guys getting tarred and feathered back in the day, they didn't have psoriasis.
They didn't have psoriasis, yeah.
But no, we don't use coal tar, fortunately, anymore. But we have a lot of good topical therapies. The mainstay of treatment that we all use is our topical steroids. Those usually are go-to. They're very cheap. They're easy to get at the pharmacy, and they can provide quick relief a lot of times. But we're limited with how often we can use them because they are topical steroids. We don't want you using them day in and day out, usually for about 2 weeks at a time, and then taking a 2-week break because they can thin the skin and things like that. But we are blessed to have a lot of other topicals that are coming out nowadays. So we have things like Zoryve and Vitama and Opzelura. Actually, Opzelura is more for atopic derm, but other topical JAK inhibitors essentially that help suppress the immune system locally and you don't have to worry about those other systemic or side effects.
So Zoryve is a phosphodiesterase 4 inhibitor or 5? 4.
I thought it was 4.
4, yeah.
I was like,
5
I'm
is
going crazy
your
now.
Viagra.
Yeah.
So phosphodiesterase 4 inhibitor, which is an inflammatory pathway. And so topical Zoryve, steroid-free, doesn't thin the skin. Not necessarily that we're trying to promote it, but it is very effective for psoriasis, also approved for seborrheic dermatitis and atopic dermatitis because of its broad anti-inflammatory effects. So it works upstream of those inflammatory chemicals like the interleukin 17, interleukin 23, TNF-alpha, and limits the development of that inflammation. Something like a Vitama does that through more of the interleukin 17 pathway in a topical form. And the data on Vitama is very impressive of leading to long-term remission of the plaques on the skin, sometimes up to 4 months if it was effective for you. We have the topical calcineurin inhibitors, things like pimecrolimus and tacrolimus used topically, very safe, steroid-free, and these all have anti-inflammatory effects on the plaques of psoriasis.
Yeah. And then you mentioned phototherapy.
Right.
Your beautiful
Shine
segue.
a little light on it. So phototherapy, generally most phototherapy is going to be narrowband UVB, 311 nanometers. And this has an effect upon the immune cells in the skin, those T cells, by decreasing their activity. Upside is no systemic side effects. You're not putting a drug into the body. Downside is it is ionizing ultraviolet radiation. If you have 300 or more treatments, it can increase your risk of skin cancer. UVA is sometimes used, particularly in something called PUVA, which is psoralen plus UVA. Psoralen is an anti-proliferative medication that can be either painted on the skin and then you're exposed to the light because the rapidly dividing cells absorb the psoralen more, or it can be taken in a pill form that then goes through the body, then you get in the light box. And psoralen plus UVA, there's really good data that it does increase the risk of skin cancer, particularly over 300 treatments. Try to limit it to fewer than that. But they often have the upside of fewer systemic side effects, fewer medication interactions. And the downside is that you have to come into a clinic 2 to 3 times a week to have them done.
It's time consuming.
It's always perplexing to me that I can recommend phototherapy to a patient and the insurance will deny it. They won't cover it. And a year of phototherapy, if you were coming 2 to 3 times a week for a year, may cost anywhere, depending on your insurance, between $3,000 to $8,000, which is expensive out of pocket, but cheap compared to they may approve a biologic medication that the retail price could be $120,000 a year, and they'll pay for that, but they won't pay for the phototherapy that has no side effects, that is significantly cheaper. It's just one of the
mysteries
problems with the medical system.
So,
but phototherapy can be very good. So
particularly effective for guttate psoriasis, like you had mentioned before. Hard to get through like hair-bearing areas and things like that. But I've seen it work great for people, especially who are probably they're elderly or they just can't. We don't want to risk doing like a biologic or a systemic medication.
There are multiple medications.
Yeah.
And for those hair-bearing areas, we have eczema laser, which is 308 nanometers, almost identical wavelength, but comes in a smaller applicator size. It's administered by a nurse or a medical assistant in our clinic. You can part the hair and treat individual. Treatment takes a little longer, but same idea. You're getting the light. It leads to a reduction in the proliferation of the skin. So...
we have a lot of good systemic treatments. So, and even before, the past 5 years or so, there were a lot of systemic treatments that we were using that helped, that carried a lot of side effects, things like methotrexate, things like azathioprine, acitretin. And those were more really immunosuppressive medications that we used, and I can remember fighting insurances because they wanted you to do all of those first before something like a biologic, which we'll talk about. Nowadays, they don't really push methotrexate. Every once in a while, I get it one, but we don't really use those as much anymore. We have oral medications, though, that can treat psoriasis, things like Otezla. There's one, which is a phosphodiesterase 4 inhibitor. So it's the systemic version of Zoryve. There's also something called Sotyktu, which is called a TYK inhibitor, and that's related to kind of the inflammatory pathways, like we've talked about, where it blocks kind of the upstream pathway, so that way it'll calm down inflammation in the skin.
The upside of the oral medications is they generally don't require laboratory monitoring. So your Otezla or your Sotyktu, they're a daily pill taken once or twice a day, and they control that inflammation. My experience, this is the way that I explain it to patients. Often they're a home run or a strikeout. They either work really, really well.
They work great, or they don't.
Or they just don't work at all. And I know the data from the company says different. They're like, oh, people get 30% better or whatever, but it's just my experience.
I've had the same experience.
Most people aren't real happy with 30% better. They either want 100% better or like, this didn't work for me. And
nowadays we have medications that will get you 100% better, or
in many more cases.
Cases. So I don't particularly prescribe those too often. A few times there's like that perfect patient. Otezla has a little bit more side effects that we have to be careful about. But that are just annoying to the patients. But now we have what are called biologics, which are game changers for our patients.
One comment on Otezla is the third most common side effect on Otezla was weight loss.
Oh, yes.
And so people would lose weight on it, and they weren't quite sure. 10 to 15
pounds, unexplained weight loss.
Unexplained weight loss, which I had one patient, and we put her on Otezla and saw her back like 6 months later, and she's like, yeah, it's not really working for my psoriasis. I'm like, we need to make a switch. And she's like, I've lost 30 pounds. I don't want to stop this.
I will say when the whole weight loss thing came out and they talked about the unexplained weight loss, the samples disappeared from our closet.
Oh, really?
Oh, yeah.
That's a federal crime.
But. I know. We're just like, where's all the samples going? But yeah, that was...
But the biologics are what really, I think, in most cases have revolutionized the treatment of psoriasis. If you've ever had psoriasis in the history of the world, now is the best time to have psoriasis. And these medicines were kind of developed in different stages. So the earliest stage of biologic medications were going to be what we call TNF-alpha inhibitors, tumor necrosis factor alpha inhibitors. The common ones are going to be Enbrel, Cimzia, and Humira. And these all have different dosing schedules. Some are injected into the body once a week, twice a week, every other week. And so there's pros and cons to each of these. And it's not the purpose to get into every nuance of these medications, but just for general information is you have TNF inhibitors. They've been out the longest, very well understood side effect profile. They do require laboratory monitoring at least annually while you're on them. And there's certain times in which you would not want to use those, like if you have a history of multiple sclerosis or lymphoma or leukemia. The next class that came out was something called an interleukin 12 and 23 inhibitor. So this hit two different cytokines, and that was called ustekinumab, brand name Stelara.
And Stelara was novel because it was a once every 3 month injection, and patients loved it. I had the same experience with kind of the oral medications. It worked great for some people and just didn't work at all for others, or it worked great and then fizzled those last few weeks and people's psoriasis started to flare. But having an option for people every 3 months was quite amazing, and it did do a good job for a lot of my patients. And then after that one was developed, the IL-17 inhibitors really came out, and we have a few in that class that came out. There's ixekizumab, which is called Taltz. There's secukinumab called Cosentyx, and then I forget the brand, the generic for Siliq. Do you remember that
Siliq
one?
is brodalumab.
Oh, brodalumab. Which no one ever wrote.
I did. So, I wrote it a few times, and it works great.
I was always scared of the like the whole like not eye pledge, but like the REMS thing. But was there any other IL-17s? Which one?
The other one is Bimzelx, which is also an interleukin-17 inhibitor. And some of these work a little bit differently. So some of them go in the body and they find the interleukin-17 and they bind to it. Some of them go into the body and they find the interleukin-17 inhibitor and they cover it up so that the interleukin-17 can't bind to it and then cause the downstream effects. But for all intents and purposes, we just refer to them as the interleukin-17 class. And I would say in general, we saw improvement in side effect profiles, although the TNF-alpha inhibitors are really darn clean. I don't see a lot of problems with them. We did find that with the interleukin-17 class, not great if you have inflammatory bowel disease.
Yeah, it can flare inflammatory bowel disease.
And a slight increased risk of fungal infections of the skin or toenails. So just something to be aware of. Sometimes people were getting thrush on them. It's not something I've really seen a lot of.
I didn't either.
But it was appreciated in the clinical trials and in post-marketing surveys. And then after the interleukin-17s, we started to get into the interleukin-23 class.
Yes.
Which the interleukin-17s were usually dosed once or twice a month. So the dosing schedule got better. And then we went to the interleukin-23s, which most of them are dosed every 3 months, like Stelara. But these, instead of being a 12-23 inhibitor, are just a 23 inhibitor.
Right.
The first one that came out was, I believe, Skyrizi. Skyrizi, you see it marketed everywhere.
Actually, Tremfya was
Tremfya,
released.
did they beat them?
They beat them. And the only reason why I know that is because I went to an ad board for Tremfya. And the whole ad board was, what are we going to do about Skyrizi
when it launches?
When it launches.
So Tremfya was first, and then the Skyrizi, and then Illumia.
Yep.
So these are all, and I don't remember all their specific generic names. I know Skyrizi is risankizumab.
Yeah.
One of them is gaselkumab.
That's Tremfya.
Tremfya. And then Illumia, I don't remember what its generic name is.
I don't remember it. I never really wrote Illumia very much.
These generally, again, we've seen improvement in safety profiles, side effect profiles, and many of these medications are now being sought for other indications. Some of them are treating inflammatory bowel disease in the 23 class. In the 17 class, some of them are treating hidradenitis. In the TNF class, some of those are treating hidradenitis. I think Humira has like 9 different indications for the FDA.
Humira had, I want to say 9 that I knew of.
So when I have this conversation with patients, we talk about the frequency of dosing. What are the contraindications? Have you had a malignancy before? We don't want to use these ones. Or do you have bowel disease? We don't want to use these ones. All of them have to have at least annual blood work to check for tuberculosis, hepatitis. We offer HIV screening before because they do lower parts of your immune system. So if you have a latent infection, something that may not be causing you problems now, but it's hiding out in there, and we take the immune system down a notch, that infection could potentially pose a risk to you. So we screen for certain infections before we put you on these. But it's not something where we're routinely monitoring the effect on the liver or kidneys because they just are pretty darn safe.
Yeah.
So.
And patients tolerate them very well. When we talk about how they're injections, some people kind of shun away from that, but they are in auto-injector pens.
Kind of like an EpiPen.
Like an EpiPen. And so you're not having to hunk a syringe into you and then push the plunger down yourself. It's a pen that will do everything for you, which is really nice. And it's some of them are very ergonomic for patients who really just, they can't grip a pen and push a button too hard. You can just kind of push down. It does everything for you. So there's a lot of variability in some of the pens that make it easy for the patients. And these have been lifestyle changers for so many of my patients. Like you said, you get the people coming in the middle of summer wearing sweatshirts and hats, and then they say, I haven't worn shorts in years, and they're finally allowed to do that. They also help, they're joint protective. A lot of these are really good at treating joint psoriasis as psoriatic arthritis, as well as the skin psoriasis, which is really nice because it'll, you don't have to be on multiple medicines to treat different types of psoriasis. And a lot of them also treat the nails, although nails can just sometimes be difficult.
It can be very difficult, yeah. Especially useful to use some of these medications when you have special site psoriasis, palms and soles, difficult to walk. I've had patients who they can't even walk. They come in a wheelchair because psoriasis is so bad on their feet, or in the groin, and they have trouble in their intimate life because somebody, potential new partners think they have an infection, or it's just not something that they want to show to anybody else because
Yeah.
they're embarrassed about it. And so even if you don't have widespread psoriasis all over your whole body, if you have just a little bit of psoriasis in your groin or it's on your feet and you're having trouble walking, these medicines can be life-changing.
Totally.
So our purpose is not to say that everybody needs to be on these medications. We're certainly not out here pitching for the drug companies, but we have seen the benefits of these medications in hundreds, if not thousands of patients. We've seen the side effect and safety profiles, and we have a lot of confidence that in the right patient, these can be life-changing medications.
Yeah. I do have an interesting anecdote about psoriasis. I had a patient once come in who he was probably looking at 60% of his body covered in psoriasis. And I had discussed a bunch of different biologics and different ways that we can treat this. And he goes, you know what, I just want to try to treat it on my own. And I said, okay, fine. And he left. I saw him about a year later and he came back and he had 0% psoriasis. I mean, it was gone. And when I asked him what he did, he changed his diet. And how he did it was using an app called Real Plans. And he subscribed to this app and you kind of create a profile. You say, I have psoriasis. I have this type of inflammatory condition. And it tailored to him and an anti-inflammatory type diet.
Wow.
And he was cured for a long time. It's a hard diet to maintain.
Yeah.
And so he came back because he said he was getting little flares here and there and would like to discuss doing like a topical.
Yeah.
But there's not a lot of good studies to show that there's really a strong link between diet and psoriasis. But it was kind of an interesting thing that I saw, and like maybe there's something there.
Yeah. Well, we talked about that a little bit in our gut-skin connection episode.
Yeah.
That this is an area where we know that there's a relationship between the health of your gut and the health of your skin. And there are certain times when your gut health, if it's poor, can increase your risk of psoriasis, of eczema, of several different skin conditions. We just don't have a lot of precise science on like, okay, take this probiotic and your psoriasis will go away.
Right.
But we know, and I've seen examples as well, where somebody changes their diet, their lifestyle, they work out more, they get outside, they change their social situation, they stop drinking, and these types of lifestyle changes lead to significant improvement in their psoriasis.
Yeah.
So not in all cases do you have to turn to pharmacologics to manage this, but they can be very helpful in supporting that journey. And my approach to patients, because they always ask, how long do I have to be on this?
Yeah.
Well, we don't know. We don't necessarily cure psoriasis.
Yeah.
But I'll put you on this. If we get your psoriasis to go away completely and it stays away for a year and you're making some of these other changes, stay physically active, maybe you need to lose some weight. And if after a year you want to try coming off, I'll be totally supportive of that. We'll stop the medication. We'll keep our fingers crossed and hope that it doesn't come back, because the pharmaceutical companies, they want you on the medicine for the rest of your life. They want you and your insurance company to pay for it. And in some cases that's necessary. But if you want to try a drug holiday, at least in my clinic, when you're seeing me, I'm always supportive of that.
Yeah. Another thing that I have had patients do is they lay out for a little bit in the sun. When they do that, I say do it in the early mornings or in the late evenings. Don't lay out in the middle of the day when the UV index is highest. But a little bit of UV can also be beneficial. That's why we do narrowband UVB. It's a very controlled way to do it. But I have had patients who say, I'm going to lay out, I'm going to do it. And we try to mitigate how to do it in a safe way. But a little bit of UV.
And we see a lot more psoriasis in the winter because patients say like, I've had this rash for a while. It usually gets better in the summer.
Yeah.
And then it always flares up in the winter when it gets cold. And so, it's not the cold, it's that you're not getting sunlight anymore.
Yep.
And again, you do have to be careful with how you do that. And we don't want patients to become a recluse either, because that impacts your emotional well-being. And we touched on the depression risk, the anxiety risk. One of the projects that I did with VTAMA on social media focused on this concept of touch starvation, where patients with bad psoriasis, their intimate partner is not, as willing to touch them, to be close to them, or in the dating scene, they can't, find somebody that really wants to get close to them. And so this touch starvation, that takes a toll on your emotional well-being as well. So we are mindful about the emotional and mental health impact of psoriasis, and that's something that most dermatologists, I think, do tune in with their patients about.
Yeah, I would agree. But at the end of the day, I feel like the future of psoriasis the future for people struggling with psoriasis is bright.
And not just because of the phototherapy.
Not because of the phototherapy.
Have to bring it back to the same jug.
That's great. You wrapped it up beautifully.
Yes, we've made it full circle. But ultimately, if you have psoriasis, it is a challenging condition to treat without pharmaceuticals in many cases. We encourage you to try whatever you can, but at the end of the day, we have very good tools to treat it. We encourage you to see a dermatologist to make a treatment plan that works for you. And this is an area where most of these medications are well covered by insurance. Many of the pharmaceutical companies have good prescription assistance plans to help you qualify for medication if your insurance company doesn't cover it adequately. Mm-hmm. So we're excited about the future treatment of psoriasis. And I think around the corner, we're going to have a test where we can just scrape the skin of the patient, get a few skin cells, send that to a lab, and they'll tell us exactly which medication to use the first time so we don't have to go through this trial and error.
Yeah, you're probably not, it's probably not far off.
Yeah. So as always, we appreciate you guys joining us on this episode of Skinfluence. Again, today for the product of the week, we want to drop Future Clinic. Future Clinic is a way that I can actually become your doctor, starting in Idaho and New York, with more states to come, where I can send prescriptions. You can get real medical advice and skincare advice through me through the Future Clinic app for a monthly subscription starting at $50. The price may go up in the future, and it's limited right now to 50 patients. So if you want to be my patient and you live anywhere in Idaho or New York, click that link and sign up, because it will fill up fast, and I'd be happy to become your physician and take care of your skin.
That's awesome.
So thank you for joining us. You can follow us at Skinfluence_pod on Instagram. Send us your questions, comments, and leave us a 5-star review wherever you listen to podcasts.